Muted.
Good morning, everyone, and welcome. This webinar is brought to you today by Strategies 2.0, a statewide collaborative funded by the California Office of Child Abuse Prevention. Today's call is Recovery, the Family Process of Healing and Hope. The call is scheduled from 10 until 11:30. I'm Carrie Collins, today's facilitator, and my role today is to introduce the topic and presenter, keep track of the time, and help the presenter and participants in any way that they might need. In a moment, I will introduce the presenter to you, but first I would like to go over a few webinar guidelines. The webinar is 1.5 hours and it will go very quickly. So in order to limit outside noise, we have muted all the participants. We encourage you to interact and we'll show you a few ways to do that. Let me switch my slide here. So all of you should have a toolbar that you see on the right-hand side of your screen. And if you want to minimize the toolbar, you push this little red button here. You can either join us by telephone or you can use the mic and your speakers. We recommend the telephone because it's a better sound for you. Down below is a chat box. We encourage you to type questions in here, thoughts, anything that you might have that you want to ask the presenter today. We will address all of these questions at the end of the webinar today. There's also a little place for you to raise your hand, and that's right there, and it will show up in my toolbox. I see some of you have your hands raised, so you might want to check to make sure that you actually have a question or click out of that. So today's presentation is being recorded and it will be provided to you within about 48 hours of today's presentation. So I would like to introduce your presenter to you today. It's my pleasure to introduce to you Steve Hornberger. He has over 25 years experience in human services and community building. He provides consultation and technical assistance to government and private agencies on cross-system collaboration, organizational change, family-driven services, and community-based services. He is particularly interested in family and community health and wellness, as well as addressing social justice issues. Mr. Hornberger was elected into the National Association of Social Workers Pioneers in recognition of his leadership, innovation, and success. He is a member of SAMHSA, National Recovery Month Planning Partners, a board member for the National Rural Institute for Drug and Alcohol Problems, and a friend of the Board of California Mental Health Advocates for Children and Youth. Mr. Hornberger is the director of the San Diego State University School of Social Work Social Policy Institute, where he administers a number of statewide contracts and local projects, expanding child, family, and community well-being. Recently, he facilitated the Priority Access to Services and Supports in Ventura County, which developed the process that 85% of new families in family reunification for a 6-month period were referred, served, and began behavioral services in 15 days. For the next year, the project is focusing on how to improve the coordination and outcome of care for these families, as well as providing this process to all families in child welfare. While in the private sector, Mr. Hornberger co-chaired the first wraparound team in New York City, creating a family-driven peer education, support, and advocacy resource center, and was the director of 18 group homes. We are very honored to welcome Steve Hornberger as our presenter today. I am going to turn over the screen to Mr. Hornberger. And there you go. All right. I'm sorry. Let's see.
So she's all go over.
For some reason, I would ask for everybody to just hold on for a moment. I'm trying to unmute Mr. Hornberger, so hold on for just a moment. Steve, I need you to enter your audio pin in order to unmute yourself. Steve, I don't know if you can hear me, but we cannot hear you at this point. There's an audio pin for you to enter in order to unmute yourself, in order for me to be able to unmute you. There you go. Nope. Steve, if you could push 79#, that should unmute you, or allow me to unmute you. So Steve, I don't know if you can hear me. I need you to call into the number in the webinar and then push on 79# after you call into the number. We apologize for the delay. Okay. So Steve, if you could call 1-510-365-3231, and your access code is 943-408-435. And your PIN will be 79#. I hope you will all stay with us. We are getting a hold of Mr. Hornberger right now, and we should be with you in just a moment.
Can you hear us now?
There we go. We can hear you now. Thank you.
Oh,
Sorry, did it drop off at a certain point?
I guess so. So glad to have you back on the line.
oh, and I was absolutely brilliant too. All right.
You were.
Oh, you heard me. Okay. All right. So again, apologies for that. And my intention with this PowerPoint is that there's more slides than we'll be able to get to in our time today. I wanted you to have all of this information simply because there's a lot to this issue, and I wanted to make sure you had all of the information that you could look at once the PowerPoint's posted on the website. There's also 3 or 4 page slides of resources that you can have at the end so that you can really begin to drill down and become much more understanding and knowledgeable about the issue and its complexity. So in these 3 questions, I guess we'll go through this again. What I'd ask you to do is just take like 30 seconds to put down the first thing that comes to your mind when you hear this. Generally in my community, when someone hears a family has an alcohol or drug problem, they believe. What is it that people in your community believe? Second one is working with the family in need of alcohol or drug treatment is challenging because why is it hard to work with these families to engage them and help them get well? And then finally, when you've been successful with a family in need of or receiving drug or alcohol services, what have you done? Now, I've asked these 3 questions in hundreds of communities across this country over the last 10 or 15 years as I do different workshops and technical assistance. And generally, the answers come down to 3 big ideas. The first one is that you hear lots of negative comments and judgments about the people that the community believes around people who have drug or alcohol issues. And that makes sense because up until recently, everybody saw this, most people saw this as a moral failing. It wasn't a disease with a consequence. It was really bad things happening to bad people, and often they got, in quotes, what they deserve, or they've made their bed, now they got to sleep in it. And so that's the negative stereotypes and the stigma that you have attached to this problem. Second one, why it's challenging is because until very recently, in the last 10 to 15 years, we didn't know a whole lot about the physiology and the biology of how this worked and why some folks were more at risk than others. If you think about it, between up until the 1990s until the 2005s, in that period, with the decade of the brain in the 90s, we tripled our knowledge base about how alcohol or drugs impacts human beings and their families and the communities and the behavior. Since then, we've doubled our body of knowledge once again. So we know a whole lot more about addiction. We know, I'm sure you've all seen those brain scans that show my brain on drugs or whatnot. And we've come a long way from that fried egg in the frying pan that was the big thing, or just saying no, which was the big thing when I was growing up. It's a difficult issue. The other piece is we've gotten to the point now we understand that it happens differently for males versus females. It depends on your body weight. It depends on your family biology, your genetics. It depends on who you're hanging out with, which drugs you're using. So there's a lot of complexity to it, and I'll go into more detail later. And the other piece is just that nobody has just an alcohol or drug problem. It's always related with carrying mental health issues, work issues, school issues, family issues, employment issues, housing issues. So nobody has just a drug problem. There are all these other life challenges that they're struggling with at the same time. And then there's always denial. So you get the picture about why it's challenging. Now, the issue about when they've been successful, it's really very interesting. It always comes down to that people are spending time and building relationship as people are going and supporting the people as they're going through the services and supports or working for their family to get in a better place. Because it's real simple. If we want people to live better lives, then they got to hang out and be with and interact with better people. And I think the 12-step programs get it right. If you want to live differently, then you have to have a sense of belonging with people who care about you, understand your issues, and can be there for support. And so that's why this audience is so important, because you are the caring community leaders or the community people in your communities, and that's what I'm hoping we'll have an impact on today, that we'll all have a better idea of what we can do in our own communities. So why are we here today? And I'm going to give you lots of stats, but I want to take the issue home. So this is a buddy of mine did this a couple of years ago. So basically, in that year, 1 in 10 Americans is impacted or by substance abuse issues. 1 in 5 families, 1 in 7 workers, 1 in 20 newborns are born with prenatal issues. A third of all the school children. You get the picture. It's a problem that impacts all of society, and it's not just a treatment program or a prevention issue. It really is, how do we begin to address this? So another way of looking at this, every year the SAMHSA does the National Survey of Drug Use and Health, the NISDA survey, where they literally interview a couple 100,000 people in their own face-to-face to get these information. So in 2014, which is the last year we had the information, 21.7 million people, 12 or older, met the criteria for needing treatment for an AOD problem. Of these, only 2.3 million people received any treatment. And that's true year after year after year. About 10 to 12% of the people who meet the criteria for the problem receive any treatment. So that there's a large unmet prevalence of need in our country. Of those 19.4 million people who needed treatment but did not receive it, only 5% felt that they needed it. That, to me, is the denial gap. Most people don't think they have a problem. They think their wife has the problem, or their son has the problem, or their boss has the problem, or the cop has the problem. But they don't see themselves having the issue. That's what I mean by denial. In terms of the 880,000 who felt they needed it, only 272,000 people made an effort but were unable to get it. That's the treatment gap, because these are people that understood they had a problem and wanted to get help, but they couldn't. And then last, but the other 70% made no effort. They felt like they needed it, but made no effort to get any help. And that's what I think of as the motivation gap. And given what we now know about motivational interviewing and stages of change, I think we in the community who have a better knowledge base can certainly do more about how engaging people who understand the problem but don't have motivation, as well as the 95% of the people who need treatment but don't make any effort. And why are we here today? Because I want to put this into a policy context. In 2005, CASA, which is the Columbia Addiction Services and Alcoholism Institute in Columbia University, they did a study trying to figure out what's the impact on federal, state, and local government. So in that year, all three governments spent approximately $4.4 trillion, and at least 10% was related to substance use and addiction. Now here's the part that troubles me, and I hope will trouble each of you as well. For each dollar spent, 95% was spent on shoveling up the wreckage, and only less than 2 cents on prevention and treatment, less than half of a penny on research. You get to see the rest. So basically, what this says is that we wait to intervene or make a difference after they've had the problem. Because the shoveling up the wreckage means you're paying for hospital costs, you're paying for unemployment, your child welfare, extra law enforcement, all of the things that we respond to the problem rather than trying to try to prevent the problem to begin with. And if this makes sense to you, you should keep doing what you're doing. If this doesn't make sense to you, then we need to start thinking about how do we raise the issues and what policies do we want to start to bring to our legislators, our county officials, our agency directors to start saying, how can we do something different to this? And for me, the message is very clear. If we don't do anything, this is what will keep happening because the status quo is the status quo. If we want something different, then we got to learn how to speak up and speak in a way that we can begin to create some change. Another way of looking at the impact, half of all children live in a household where a parent or other adult use tobacco, drink heavily, or use illicit drugs. Now think about it. Remember a bunch of years, I guess it's about 8 years now, where one person came down with SARS, the illness that's airborne, and everybody was running around with white masks to prevent it, and CDC created a crisis. One person died from that, and we made it a crisis state. And yet here we are, half or all of our children are living in a place that we know has a negative impact on their well-being, and we just go about our business. We're not thinking about what else we can do. Again, the 13%, where a parent use under 12, where a parent is using alcohol, illicit drugs, and 1 in 4 children under the age of 18 in their lifetime will live with a family member who abuses alcohol or has alcoholism. Intergenerational Connections, which is why I'm so excited about we're doing this with Strategies 2.0, because I think this is an incredibly important platform to make a difference about improving child, family, and community well-being. In one study in New York State, 45% of all the clients admitted to being a child of an alcohol or substance abuser. That's that intergenerational account. A child of an AOD abuser is 3 to 4 times more likely to develop their own AOD problems. And in one study, in the original study about women in treatment, 90% of all the women in residential substance abuse treatment reported child abuse or neglect in their background. So these issues don't go away. They go from generation to generation, and I think it's only when we realize that these are community problems and not just a child welfare problem and not just a substance abuse treatment problem, but a community problem, that we'll be able to bring together the resources and the knowledge and the people like yourself to make a difference. So in terms of California, some behavioral health facts that I pulled out from the recent NISDA report. Again, these are just, this is what we believe about these issues. And the reason beliefs are important is because if you don't believe it's a problem, you keep doing what you're doing. We need to start raising awareness so people understand the consequences of this. And we've been doing a good job in these last few years. Use is continuing to decrease, but as you can see here, 60% of 12 to 17-year-olds still don't see no great risk from drinking binge drinking at least once or twice a week. Again, here's some usage. Again, the mean age of first marijuana use was just under 14, and that sounds okay, because you figure a 14-year-old, they're making some wise decisions. But for families involved with child welfare or people who are living in who are vulnerable, I know of kids that have been starting and using both alcohol or drugs or marijuana as young as 8 years old. And so try to imagine the consequence on their own physical and emotional and mental development at that age. Again, here's tobacco, so on. Yeah, this is again the gap and how readily available treatment is for when people are 12 or older. Some issues on mental health, and because I think it used to be mental health is on one issue, substance abuse is another, a different department, and I think California, like most states at this point, have integrated both mental health and substance use into behavioral health departments. And that makes more sense because while there are some folks who have substance abuse problems only, and there's some folks who have mental health problems only, most, if you have one, you'll see the other is in there as well. Now, why is this important? Again, to build on the intergenerational and the family impact, it's pretty straightforward. Someone who's a parent who's abusing alcohol or other drugs is obviously going to be less attentive when they're drunk or high, will be compromised in their ability to fulfill their role as a parent, and is more likely to be diagnosed with a comorbid psychological problem, so that they're hampered in their ability to be a good parent, even though almost all family parents I've been involved with who have an alcohol or drug problem really do love their children, and they really want their kids to do well. It's that denial and the complexity where they're not able to do as well as they'd like to. Again, some more consequences about use and how it impacts on the family life. Now, all of you know about the adverse child experiences and the adverse child ACEs connection. I don't need to spend some time on that, but for me, the issue here is when you look at the study and you start to see both the original core group of the 60,000 people and now in other state places where they've done some screenings on ACEs, what we've come to understand is ACEs, adverse childhood experiences, are fairly common. And if you have one, it's likely you're going to have four. And remember, the ACEs, childhood experiences, living with mental illness, living with a substance abuser, domestic violence, jail, physical, emotional, sexual abuse, physical or emotional neglect, death. So these are issues that happen in life, and we now understand that the more ACEs you have, the more negative consequence it's going to have on your healthy development and healthcare status as you go older. In some of the research that's been done nationally, someone with a severe mental ill health or substance use problem on average dies 25 years younger than everybody else. That's the cumulative effect on the development of healthcare status. These diseases are chronic and they have a consequence. So the earlier we can get involved and make a difference, the healthier our people will be. So hope. So I realize I painted something of a bleak picture, but there's a lot of hope to be had right now. And so first of all, and I apologize, I have never figured out how to get this slide to come up all at once. So the National Prevention Strategy that we're currently operating under, highlights that healthy and safe community environments matter, as well as clinical and community prevention services, as well as people that are empowered to end the elimination of health disparities. Because in this country, we understand that these issues affect different populations very differently. That's the nice way of talking about discrimination and inequities. The prevention strategy now highlights some very important things, I think, to our discussion. One is tobacco-free living, preventing drug abuse and excessive alcohol use, healthy eating, active living, mental and emotional well-being, reproductive and sexual health, and injury and violence-free living. That we understand that we've begun to appreciate how interconnected and interrelated these behaviors and actions have on ourselves and the people around us. So because basically what we've come to appreciate that there are 5 causes that account for 66% of all deaths: disease, heart disease, cancer, chronic living, stroke, unintentional consequences. And if you have an alcohol or drug problem, your rates of disease and your rates of early death are much higher than someone who doesn't have that. Now, I'm assuming, well, before I go back to that, the other national and federal priority that I would highlight for you here would be Healthy People 2020. You know, every year, every 10 years, the feds come together with a lot of key stakeholders and put together what would be our goals for the next 10 years. And what's important to me is, for the first time in Healthy People 2020, and you can Google it and get all that information, they identified social determinants of health. Basically what they've come to appreciate is that these diseases and consequences don't happen in vacuums. And where people live, work, play, and pray matters. I did a presentation last week, and one of the highlights, one of the bullets I gave was that if you're living in Stockton, California, your average life expectancy is 73 years old. If you live in Irvine, California, your average life expectancy is 88 years. So just where you live has a 15-year consequence in terms of life expectancy. These are the kinds of things that we're coming to appreciate, that how wealthy you are, what resources you have, what's in your environment makes a difference to your being healthy. Because we've come to appreciate, well, I'll get to that in a second, that there's some different models about health now. The other piece here is I wanted to highlight the Search Institute and the 40 developmental assets. I'm assuming people on the call are familiar with that. They have it for adults, for late adolescents, early adolescents, and young children. And basically they grouped them into 20 external assets and 20 internal resources. And I think they're pretty straightforward. Don't need to spend any time in those. Again, boundaries and expectations, use of time. Those are the external. The internal ones are commitment to learning, positive values, social competencies, and positive identity. Now, for me, what's important about these assets is that A, none of them cost money. They're all about relationships. And B, a friend of mine used to be the director of research at the Search Institute, and he told me a pretty staggering statistic once. He said, Steve, you know, we've done thousands and millions of these surveys in countries, in cities, big and small, and rural areas across America, because they've been around since the early 1990s. And one thing seems to always come out, and he said, if a child has 30 or more of these competencies, the chances of them having a rotten life, you know, winding up in child welfare, being in jail, you know, having an addiction problem or severe mental illness, is less than 2%. And he says if a kid has 10 or less competencies, the chances of them having a rotten life are 90%. And so basically what you're seeing here in that statistic is those social determinants, that's the ability to have internal and external assets and people who care about you and what's going to happen to you, has a profound impact on the life chances and their outcomes and the quality of life that the children, the family members, and the community will have. And I think that as we strengthen these learning communities and we get more and more interrelated and deeper into the community life, I think we have an opportunity to fundamentally change that. Sometimes when I'm feeling down or tired, I wonder what would a community look like if every kid had at least 20 assets. And it's an imagination question for me, and then it just gets me fired up and motivated to keep going. I believe that all children should have that opportunity, as well as all family members. Now here, in terms of the complexity, then I just pulled this down off of NIDA. There's lots of information in the National Institute of Drug Abuse. We've got incredible resources about what the behavioral and the biological consequences and pathways for this drug. And basically it talks about history, environment, psychology, the drugs, the main, and for me, I like this chart simply because it helps highlight the complexity. The one piece that I don't think it gives out well is that it also doesn't highlight the fact that different drugs have different degrees of addictiveness and potency, and we're certainly living in times now where the drugs that are for sale or on the street are much more potent than they were when, say, the 60s and 70s. So for some people who grew up in use, they're very different now. And we also have new drugs that, when I was growing up in the 60s and 70s, it might take 10, 12, 15 years before you moved from use to problem to addiction. Now we know with some drugs that it's happening literally within a year, literally, depending on your biology, within 2 or 3 uses. It's just very different now than it was before, and I think we need to become much better shepherds and stewards of good information so people can make better decisions, because the people on the street who are selling aren't concerned about people's well-being. They're concerned about how much money they're going to make. Yeah, I still can't get past that. So now, I just want to do quickly some risk and protective factors. I think this is pretty straightforward for this audience. So a risk factor is something in a person's life that increases the chance of a problem. And for AOD issues, you can see what they are. Pretty straightforward. I don't think there's much we need to talk about there. In terms of family experience, lack of loving, caring, and support makes sense. The low expectations, poor or inadequate supervision, lack of family rituals. And by that I mean, it might mean going to church or other such things, but it also means family picnics and, how you celebrate birthdays amongst your family members. And I remember one family member said, well, every night when my kid goes to bed, I spend a little time, and sometimes I tell a story or just listen to them, but I've come to appreciate something that I learned along the way. And basically every night before the kid's ready to go to sleep, I sit with them, we go over the day, and I say to them, well, what did you do today that you're proud of? And sometimes the kid has something to say and sometimes not. And then the other part of it is, and what are you looking forward to accomplishing tomorrow? And I love those two simple questions as you're talking with the child, because A, it sort of makes you have a way to close one day and get ready for the next day. And the idea that a kid can be proud of what they did or what they forward to accomplishing something in the next day certainly raises their sense of competencies, their self-efficacy, their self-agency, that they're more in control of themselves than we might give them, that they might believe otherwise. Protective factors, again, straightforward. I don't think there's anything here that I want to spend much time on. But again, these are slides that you can have and download and use as you do presentations or engage community people. And I'm hopeful that you'll do that, frankly. Somebody said, are they proprietary? I said, no. We got 21 million people in this country who aren't getting the help that they need. No, there's nothing proprietary about this. And again, here, the way to demonstrate or help families focus on what could they do is protective factors. Now, when people have done lots of research around resiliency, which is sort of a thread that moves through those risk and protective factors, some clear conclusions always were identified. One, people are always more important than the program. So you, as the people that are sort of the point or the place to distribute this information or engagement in the communities, are more important than any one program. Obviously, we've all heard the story about like one person makes the difference. And I can give lots of stories about that, but I have a hunch that you in the audience are sometimes the one person that's made the difference, or know of people who have been the one person. Human beings need somebody that cares about them and hopes that they're going to, and is going to stand next to them as they go through the things that make up their life. The idea, and it's sad to me, but there are many families that have no clue what a healthy family looks like. And so education and programs that help them understand that give them an opportunity to say, okay, now how can I do that in my family? What can I take from that knowledge and put it in my family? And last, this Gandhi story. The story goes like this. And I figure you all know who Mahatma Gandhi is, the person that did all the nonviolence in India and became the first president. And the story goes that his vice president and his wife had a teenager who had juvenile diabetes, and was having a really hard time following the regimen, eating differently, taking the needles, to live. And so, but they knew that the child adored Gandhi. And so they said, dear one, could you speak to our child about how important to follow the doctor's advice is? And he looked at them and he heard the story and he said, come back in 30 days and I'll give you an answer. And they left but were rather perplexed, like, why do we have to wait 30 days? So 30 days later they come back and he says, yes, I will speak with your child and talk with them about how important it is and how much their life matters, and I look forward to seeing what we can do with them. And so then the wife says, but sir, why did you make us wait 30 days? And he said, well, I wanted to experience what it was like to live without sugar for 30 days before I could talk to your son about what it's like to live without sugar for the rest of his life. And I was always touched by that story because it's clear that he wanted to be an authentic messenger and be able to speak in a deep and important way. And my belief is that each and every one of you is an authentic person and brings authenticity to your work in the community, because you're some of the key people in the community that care. And that counts for a whole lot. Often people who are struggling with the problems that we're trying to intervene with, because remember, our mission in Strategies 2.0 is to prevent child abuse and neglect and promote child, family, and community well-being. And people need to know that there are people who've gone before them. Some of us we all have our own struggles, and the issue becomes, how do we use that to demonstrate and be real to the people that we're going to help. It's one thing to just tell them, do this, and nothing happens because it's just words. It's when they can share a life experience or they understand that you're there with them no matter what, that we make a difference. Here, it used to be use or no use, healthy or not healthy, and I think we've come a long way in terms of social determinants of health and the World Health Organization to appreciate that wellness is more, and healthiness is more than the absence of disease. That it includes physical, emotional, and social and spiritual issues as well. And so that we're starting to see that, and I don't think this is the time to, we won't have time to go through a lot of this, but I did want you to highlight to you that wellness is now a much bigger idea than just healthy. And frankly, as I said once to the executive director of the Institute of Health Improvement, health is much too important to leave just to the health system, that all of us have a role to make sure that our communities are healthy. One way that the healthcare system is going about this is this idea of person and family-centered approach. And again, here's some ideas of it. I think it rings true and would be real valuable for what we do. And there's lots of resources about that at the end of the PowerPoint. But I wanted you to realize that there's new thinking going on about this issue in terms of wellness and healthiness. CMS has actually defined it and now reimburses, so you can actually bill for person and family-centered services. It's personalized, personally defined outcomes, and it's in collaboration with others. This is what Strategies 2.0 is learning and demonstrating amongst our 3 agencies, as well as the stakeholders and the community people that we're working to engage and help behavior change. This is a way of how you could put together this person-centered plan. Again, I just want to give you a roadmap. I don't want to spend time on it now, but these should not seem surprising or unusual or not likely for us to be able to do. So now, if there's hope, then there's healing. So what are the caregivers, the family members who have struggled with the problem? They need to be able to find words to share their experience. Often I hear adults and parents feel so ashamed of their behavior that they don't know how to talk about it. And the children and the other family members need the words so that they can understand it and make peace with it. Otherwise, they're just left with all of the consequences that we talked about earlier, or the lacks, and that's not sufficient. They need understanding that this is a family disease. It's affected the identified patient as well as the other family members in terms of secrecy, shame, silence. People need time. This would happen overnight. It takes some time. It takes activity. It takes caring. And then they need to figure out ways that each family, and it'll be different for each family, how to make amends and develop forgiveness to one another. Now that's true if it's the adult who has the substance abuse problem, or and certainly in California and every other state, it could be the adolescent that has the problem. Now children, but using this as an example of assuming it's the adult and the children, so children need words to say what happened. You know, what was their experience of it? They need to understand that this is a family disease and what happened to them is the consequences of the family member, the adult who had the problem, heal, and most important, kids need to understand that it wasn't their fault. And you all know, if you're kid people and children, you know, who work with families, that the kids think it's always them when something's not going well in the household, or maybe sometimes the reverse. It's all them when things are going well. But they need to appreciate that it's not their fault, that their mother or their father didn't do those things because the kid didn't do something. It's really that this is the consequence of this disease, and it has some predictable stages and impacts along the way. Now, why is family involvement important? Because often, you know, this is in the 60s, 70s, somewhat into the 80s, family, if one person went into treatment or counseling, the rest of the family members were engaged too. And then as financing and managed care and budgets got tight over the 80s, 90s, it became more the exception rather than the rule. And yet, if we appreciate that this is a family disease, then we need the whole family involved if they're going to all get well and be able to support one another going forward. So that's what that means about because it works. It's the right thing to do. You know, family groups say over and over, nothing about us without us. Well, it's the same thing in this family, in one family. And we live in some good times in the sense of stakeholders, whether it's public officials or managed care companies or health plans, or county, your agency supervisors and administrators. They think they come to appreciate that the family needs to be there and we need to do something about it. And obviously, as system reforms are happening, families are now becoming more important. So right now we're living through the Medi-Cal redesign, the ODS, and so family work is once again on the involved. The Medi-Cal 2020 waiver that's coming, that goes into effect 2019 and going forward, includes whole person care, and that means you're going to have to address those other issues and the complexity, including the family. And actually, the 2020 waiver also includes payment for recovery services and supports. So things are happening, I guess, is the shorthand for this slide. Here's some information about it. Treatment involving families are much higher. And for me, the way I understand it, or I've come to appreciate this, is that if you're involved, you're more likely to own the process, own the service plan, own the action. And if you own it, you're more likely to improve the outcomes are improved. But for me, the issue is that we need to pay attention to exactly what we mean when we say family involvement, because it can go from family friendly to family focused to family centered to family driven. You can appreciate that there's a difference in each one of those areas. And I remember when I was the director of behavioral health for the Child Welfare League, agencies would say, oh yeah, we're family driven or family centered. And I had the opportunity to go visiting a lot of them. And when I would talk to family members, they say, well, they're kind of family friendly. You know, they're nice to us, but they don't have services in the evening. They don't ask us what we want. They sort of just keep telling us what they're going to do and what we have to do. And so there is a difference between what professionals believe about family-centered and family-focused and family-driven and what family members experience. And I think as we keep going forward, I think our different perspectives are getting clearer and clearer, and I think especially in California at this point in time, I think there's a lot of reaching out to families, and I think there are a lot of families that get involved. I certainly know some really powerful and important family advocates, but I think we still have work to do in terms of making sure that that family voice is broader, more diverse, and more focused on issues. Too often in my mind, it's one or two people, and that's a heavy load for one or two people to carry if they're trying to represent and speak for all families. And clearly, a collaborative partnership of expertise, resources, and experience. And by that what I mean was, I remember when family, some professionals who struggle with these issues in their own family life would say, well, I'm at a table with family members and, I'm a family member too, so I feel like we have I bring the family voice. And the way I was able to differentiate that, I said, are you at the table because you're a family member who's receiving services or struggling with this issue, or are you there as a professional? And they would say, and then they would look at me perplexed, and I said, are you getting paid your salary to be at the table? And then they would say, yes, that's part of my job. And I'd say, well, then you're not a family member, because it's a different experience. And that's why, for me, it's so important for us to organize families and have numbers of families, be it numbers of tables, because it's easy to have one or two, at least this point in time. I think our issue is now how do we bring more and more into the mix. So, yeah, I went over this before. Now for children, is the 7 C's that NACOA, National Association of Children Alcoholics, has highlighted, that kids need to know I didn't cause it, I can't cure it, I can't control it. But I can take better care of myself by communicating in my families, making healthy choices, and celebrating myself. That the children are, I guess I think of it as they're entitled. They should have the opportunity to live a good life, irrespective of how their family members have struggled with this problem. In some ways, no different than if a family member contracts heart disease and dies early. There's crisis, there's grief, and then they move on because they still have their own life. That's true here as well. And clearly, each family is going to be different, but basically what families are relearning is how to assert and have authority and discipline with the children, because obviously when they were using, there was very little authority and discipline. What are the new roles or re-emerging roles or reclaiming the roles and responsibilities as being a parent and the child? We all know about children who become the adultified child, the older child that takes care of everybody. Well, they have a right to have their own childhood and their own adolescence, and especially when the parent is now able to reclaim and fulfill the role as a parent. They need to do more new problem solving and communication, because often this disease breeds silence and we don't talk about it either outside or inside the household. We need to be able to talk about what we're feeling, what we're seeing, what decisions we need to make. Obviously, all families should have fun together, and we need to begin to start showing affection. One way to help a parent who's in recovery would be to help them understand their family and situation and environment, as well as what's available to them in the community. This just helps break down rebuild some of the bridges that may have been damaged and or burnt when they were in using. Because this helps them have some more support or more resources or allies, if you will, within the family, as well as whatever they're going to develop and maintain outside the family in terms of, it could be 12-step programs, it could be some other things. There are many pathways to recovery. We'll go over that later. But clearly, again, as I said in the first slide, nobody gets well and stays well by themselves. We need a sense of belonging in other people. And so this is just one way to map it in a family. In terms of family involvement, I put together a issue. It's not just a prevention issue. All the major health and human service systems are moving to this direction. Sometimes they call them patient-centered, sometimes they call them client-centered or consumer-centered. You know, there's different wording, but they're all doing this, engaging. How do we engage the people we serve? Because, as it says here, their values, preferences, and expressed needs really matter if we're going to be successful. So here's with the Institute of Medicine. There's an Institute for Patient and Family-Centered Care that has assessment tools and guides. There's some others listed at the end in terms of Institute for Health Improvement. There's just lots of resources. Child welfare, I'm assuming all of you know about the Child Welfare Information Gateway. And so they have family-centered and strength-based approaches and lots of information about that. Juvenile Justice, which was probably the last one to come online with this issue, has a network that actually has a whole methodology and examples of how family members are getting involved in juvenile justice. So now, what is recovery? You know, we've been talking to it, and I just want to highlight this a little bit. So this is the first thing that matters is that recovery is from a disease, and that for many people, depending on the severity of the impact and the length of time that they were struggling with the problem, they may need continuity of care over a lifetime. Science says that obviously recovery works, treatment works, and recovery is possible. Those are sort of the mantras of SAMHSA. Here's some results about how powerful treatment is. And I think, again, the Medi-Cal redesign in California is expanding both outpatient and residential care, will certainly be helpful. And many people get well from this problem without receiving treatment. And so that depends on community supports, engagement. You know, they get a new job. They get involved in their faith-based organizations. They fall in love. They move. I mean, there's lots of ways that people can get well. But treatment is clearly is indicated for a large percentage of them, and it's good that we're now expanding our treatment beds and slots. Here's a way of why continuity of care is important in terms of treatment. Can't beat that stat. If every dollar spent on treatment, we save $37 in benefits, and by that means less hospitalization, less unemployment, less jail, less child welfare. You know, these are, sometimes people get caught up in the different systems about cost sharing. Well, I can't spend it because I won't see the benefit. And I think if we take a more of a community perspective, we get to see, well, if this reduces my costs over the next couple of years over the, with all these other services, this is an investment I should be involved in. Again, there's a whole body of research now in recovery, and it's been updated over and over again. I'll give some resources. Now here's the issue, because people always say, well, relapse is part of the process. And the truth of the matter is, some people relapse. But the truth of the matter is also a large percentage of people don't relapse. And if you look at these numbers, you can see alcohol or substance abuse problems are no different than other chronic conditions in terms of illnesses. For me, the issue about relapse is part of the process. It highlights the idea that language and our expectations matter. Yes, we can respond to relapse if it happens. It's a learning opportunity about what needs to go wrong, what needs to be different going forward, but it's not inevitable. And I don't think it should be our expectation. We respond, but don't expect. So your definition of recovery, and this is where I'm missing that we're not in the same room, we can go back and forth on this. These are different points of view. I always like the last one, obviously, recovery is life, because I didn't have no life before I got into recovery. But I remember when I was growing up, and for most of my adulthood, recovery was defined as one day at a time. Well, we've learned a whole lot more about recovery and the consequences and how to intervene. And it's more than just one day at a time now. SAMHSA has a new working definition which highlights health, home, purpose, and community, because by the mid-2000s to 2010, we tripled our knowledge base, and we came to understand that if you want recovery, then we need to make sure that the person is healthier. He needs a stable and safe place to live. If you don't have a stable house, I don't know of any person who's ever succeeded in recovery with not a stable house or place to live. Purpose. Each of us needs a purpose. I mean, why do we get out of bed every day to do things? How do we find meaning in what we do? Because we all live in a society that says, yeah, you consume things, you buy things, you eat things, but we also need to make a difference. Otherwise, we feel like we're just going through the motions. And I can't imagine any of you on the phone or go through the motions. And I think you want to highlight what your purpose is so that you can engage the people that you're going to work with on what their purpose is. And obviously, community. Without a sense of belonging, there's no sense of wellness, there's no sense of purpose, there's no sense of making a difference. And so we need healthy communities. And that's why, for me personally, I'm so excited that OCAP and this Strategies 2.0 widened the focus from preventing child abuse and neglect critically important, but understanding that that's only like half the issue. The other half of the issue is we need to promote child, family, and community well-being, because with both the prevention and the promotion, I think we're going to make a difference to lots of children, families, and communities. And I look forward to what we're going to build together, create together, develop together over these coming months and years. And basically, what the AOD world has moved to is from how do we get the client into treatment to how do we support the process of recovery within the person's life and environment. And it looks like this is a fun slide, because basically it's saying all these pieces in a person's life and the opportunities and the resources in the community contribute to the ability to stay clean and sober and move forward. So some closing thoughts, because I figure about another 5 minutes or so, and then I'll throw it open to any questions. So for me, my vision about this issue about substance use and alcohol and tobacco is that I think that we need to have communities where all members of the family affected by these issues know that there are knowledgeable and caring others who understand what they're experiencing, care about them and are available, can help them find emotional and physical safety, and can support their healing, health, and wellness. If you don't know that's out there, then you just suffer. And all of those negative beliefs and stigma that I talked about in the first slide in those questions, that's what the people struggling with this problem live with too. They're part of the society, and so they've taken in all of those messages about themselves. I burnt my bridges, I got to live with this bed, this is the price I paid for all of those horrible things that I did, et cetera, et cetera, et cetera. We need people to say, yeah, you did some horrible things, some bad things, some destructive things, but now you've prepared to start turning your life around. And so how do we start to help you heal? How do we help you get more healthy? And then how do we help you reach for and achieve and live with wellness? Because the truth of the matter is, human beings can turn their life around, do live better lives, and people get well. And I think that's the message we need to make sure we have and make sure we share with the people that we're getting involved with. There's this other idea that quality care now becomes a driver of change. It's no longer just sufficient to look at how did you comply to the program. It's also how does the program improve your quality of life, so that more than just clinical outcomes, you improve this much on the screening and assessment tool, to how are you better prepared to live in the real world. And that these measures that we're going to start to look for need to track outcomes over time. Because what I struggle with and how I understand my maturity level when I'm 25 is going to be very different than when I'm 35 or 55. And right now we tend to look at quality outcomes and quality of life very targeted to when they were leaving treatment and the immediate thereafter. And I think we need to learn how to measure our impact over time. So now, what can each of us do personally? So obviously we need to take good care of ourselves, our family, our friends, and our colleagues. You all know somebody who burnt out or sort of got dried out and sort of just goes through the motions. This is incredibly hard work, engaging and supporting and motivating people who are vulnerable and living with the hard things about our society. They live with the most sets of problems. And so it's hard work. And so you need to figure out, how do you keep yourself motivated? What do you need to do to recharge? How do you find hope for yourself? It's always a fun question to ask. How do you know, what can you do to find hope? For many people, it's their faith tradition. For others, it's their friends. For others, it's hobbies. We each have a different mix of it, but we need to make sure we do it. We need to learn about addiction and recovery. We need to collaborate because no one system has the resources or the reach to make a difference at both the clinical issues and the social issues. And so we need to learn how to become a change agent because the status quo just is insufficient. It's a good base, but we need to do more. And one of the ways we can do that is define and monitor outcomes at 4 levels. And by that I mean the child and family level, the program level, the system level, but also at the community level. Because if we're only serving 10% of the population that has a problem, even if we're 100% efficient and effective, we're still not going to have an impact on that other 90%. So it doesn't address inequity or disparities. It doesn't address all of the other community level issues. So that we need to think about what's the difference we're making in the community as well. And certainly here, be bold. What would your community look like if everybody lived better lives, where children are safe, healthy, happy, and educated, and where people achieve their aspirations? If we think about that 25% of all the children are struggling with this, right, what would it be like if all 25% of those children didn't have these issues to struggle with and all of their family members were healthy? So we would have almost a much reduced child welfare system, a much reduced so on, so on, so on, so on. What would your community be like? And if we can start to imagine and talk about where we want to get to, as well as what we're not happy with or what we're struggling with, I think we begin to start moving in that direction. You know, it's like bobsled drivers or runners, you know, you go where you're looking. So if we can go to the communities where we can imagine where these things exist, I think we're on this pathway there. And I look forward to dialogues where we can try to imagine and have sort of some agreement or consensus on what are some of the things that we want to see in our communities for our children and families. And obviously, personally, we can also provide hope. People who are struggling with these problems, especially if they've been struggling with them for many years, don't see any other way out. That's when you hear people talk about they're medicating themselves, because they don't see any other way. At least this way is familiar and they know what to do. So we need people who can say, I see where you are now, but I can also see you getting better. Because initially, as you're building relationships, that's what the other person needs to start to change. And without that sense of hope externally, it's hard for them to create that change, that hope internally. That's what each of us provides when we have our dialogues and our engagements with. So now, what can we do together? Well, we can raise awareness. We need to start helping people understand the complexity of this and the consequence of these issues. We need to find allies. By ourselves, we're not going to make a difference. We need to bring other people to this issue. We need to take action to end silence, stigma, and disparities. Those are horrible consequences of how we've organized and lived our lives in society in these last years. And I think we've finally got enough information and technology and communication and interrelationship that we can make a difference. You know, it's just like the people in recovery spent 10, 12 years but raising the issue until finally people said, yes, this is a illness. It's not just a moral deficiency, and yes, people get well. It took a lot of bravery for those people in the late 80s to stand up and say, I'm an alcoholic, including several Congress people. But that's the way that we need to begin to break down that stigma, and then we need to address the disparities, because this disease affects different populations very differently, and we need to make sure that that changes quickly. And obviously promote the many roads to recovery. When I was growing up, everything in recovery was you went to the 12-step meetings, and that's how you got well or stayed well. And as we began to learn more and more about this illness, we also began to learn more and more about the process of recovery. And I will salute the people and the leaders in the 12-step programs that said, we're not the only way. And so now if you go to the SAMHSA website and go to look for recovery or wellness, you'll see that there's a wellness wheel that has a number of different ways that people get well. And that's something that we also need to understand. So for me, as we address this issue, again, this is what I hope, and this is what I work towards. Communities where everyone is safe, healthy, educated, and well, where each person has a sense of belonging, purpose, and opportunities to achieve their aspirations. I hope you're going to join me. So now I just want to run through some resources. The National Center is literally in California. All of these, you just go up there and you'll find lots of information. I don't know where you are in terms of your knowledge base or what the issues you're working on in your communities. So I figured I'd give you as many as I could, that I thought were useful and helpful, and then you would find your way. And obviously, as Carrie said in the beginning, as we go forward, if you have questions, we can still keep going on that. I'm assuming, no, I'm not assuming. I know that OCAP is concerned about the impact of substance abuse in this grant, so this is something that we will come back to over and over, and I look forward to the resources and the results that we create. Again, there's a lot. When I talked about tripling and doubling the knowledge base, these are some of the ways that that's been done. If you've never heard of William White, I would suggest you spend time at that website. He is a national treasure. He's just a brilliant thinker, doer. He's a hero in the recovery community and peers. He's literally got, I guess at this point, probably 300 or 400 papers on all sorts of different topics listed by year, each year on this website. And you can just go browsing. Which one looks interesting to you? Read it, keep going, read it, keep going, because this field and this body of knowledge is still unfolding and growing. The Institute for Health Improvement, how that document has a lot of how-tos and the whys for partnering with patients and families. The Institute for Patient and Family-Centered Care I mentioned earlier, Child Welfare Gateway, Juvenile Justice. PCORI is part of the Center for Medicaid and Medicare Services, and it stands for Patient-Centered Outcomes Research Initiatives, and they have they've been at it for probably about 6 years now, and there's lots of information there about how to engage patients and their families, and this rubric is what to do and how do you engage the patients and families in the research problem, investigating the research, understanding the research, and then disseminating the research. That patients and their families need to be partners throughout that process. High impact leadership is some really good information about the white papers. Again, if you go to the NISDA, that's the 2013. Obviously, the 2014 is up, and the 2015 will come out in another couple of months. So you can just keep seeing what is happening in California and how things change. I think motivational interviewing with adolescents is just a good document, and I would urge each of you in your local communities that I know different systems now provide training on motivational interviewing and stages of change, and that would be something that we all need to get stronger on. And again, if you need to contact me, that's the way to do that. And Carrie, how do you take this back so that we can see?
I will take this back from you.
Thank you.
All right.
And again,
so I want.
I just my deep appreciation and thanks for each of you and what you do every single day. I meant it when I said this is not easy work.
I want to, on behalf of Strategies 2.0, I want to thank you, Steve, for sharing your knowledge and wisdom with all of us today. And for so many of the practitioners out there, I know that those pages of resources are just so valuable to all of them. Before we close, though, I'd like to direct you all to the chat box and give you an opportunity to ask any questions that you might have of Steve. And also, we were wondering if you had any follow-up needs in regards to this particular webinar. You know, this we can actually get a printout of the chat box so we can find out what some of your follow-up needs might be. And also, we're interested, September is Recovery Month, and we're wondering out there if any of you have some activities going on in your individual agencies or city or county or state, if you could also indicate those in the chat box. So I want to wait for at least a couple of minutes and get you all a chance. I'm getting a lot of thank you, Steve. I love all of the hopeful tips. Thank you, great webinar. Very helpful. So I don't want to close out until you have an opportunity to ask questions, comments. And then somebody had asked about when this would be available to them, and within 48 hours we try to upload the PowerPoint presentation and also the recording, so that will be made available to you and a link will be sent to you that you will be able to access this.
Yeah. And I thank you. I appreciate the thanks. I look forward to seeing what the learning communities can do regarding engaging other stakeholders and doing something for Recovery Month, which is September, so we've got some time. I think that it's a good, how do I say this? It's a powerful way to help people who are struggling with this and or who are now strong, in recovery, to stand up and be able to help the people in the community realize that there is hope. Because often it's seeing somebody else who's had this problem and now is on the other side that gives them the motivation to say, well, I can do it too. And I think sadly, in terms of admissions into child welfare, the statistics across the country are someplace between 70 and 85% of all kids and families that get involved with child welfare. Substance abuse is either one or two of the issues of why they're in. It's a pervasive problem, as you saw with those early slides. And I think we need to begin to reach out to the rest of the community, because these are community-wide problems. You all know that some parts of town are worse than other parts of town. How do we make sure everybody has an equal opportunity to live a good life?
Those are really strong words that all of us need to think about and apply in the work that we're doing. So I really want to thank all of the participants on today's webinar. Just know that you will receive an evaluation. We'll come to you shortly after, and we really encourage you to complete that evaluation. It helps us in the work that we do to make things better for you. We also encourage you to go to our website at www.strategyca.org so that you can find out what's going on in the state and what kind of trainings and opportunities we have available for all of you. So thank you all so much for participating today, and we look forward to having you join us for future webinars. Have a great day, everybody.